Thank you for joining us for our second seminar as part of the Disability Visibility Seminar Series. This is being brought to you by the Disability Visibility Focus Group, which is part of the Equality, Diversity, and Inclusion Committee at ICH. I'm really excited to welcome our two speakers today, Dr. Lola Solebo and Lucie Teoh. Dr. Solebo is a NIHR clinician scientist based at UCL's Great Ormond Street Institute of Child Health and is also a consultant pediatric ophthalmologist at Great Ormond Street Hospital. Lucie is a PhD student in the Population Policy and Practice Research and Teaching Department at ICH. Working with Dr. Solebo, Lucie's project will be used to link administrative hospital and mortality records to explore healthcare use and outcomes of children with vision and eye disorders in England. So I'm going to pass over the presentation to our speakers. Just to let everyone know, we have a Slido and the code is in the chat as well as the first slide. So if you have any questions, can you please put them there and save them for the end of the presentation. Thank you.
Thank you very much, Dana, for that introduction, and thank you for inviting Lucie and I to speak as part of this really important seminar. And thank you to everyone who's joined on what is a lovely sunny day to hear us talk about childhood vision impairment and blindness in the UK. We're going to start off by talking about childhood visual development and then talking about the challenge of defining visual impairment. We're going to spend quite a bit of talk talking about the findings of the BCVIS 2 study, which we'll hear more, of course, later. And then we'll finish off by talking about the impact of visual impairment on the individual. So you only have to look through the key milestones within the Red Book or the personal child health record, that record that's given to every family who has a newborn in the UK. You only need to look through the book to see quite how important vision is, how integral vision is to global child development. Many of them key milestones within the Red Book are milestones that really are only achievable if the child has a good level of acuity, things like staring at your hands or grabbing onto small things to pick them up using your finger and thumb. Apologies for the automatic timing on the slides. Smiling at a recognized face. Those are things that need a certain level of vision in order to accomplish. Now, before we talk about disability, let's consider the visual functions and how vision develops in childhood. And to take you through the visual functions, I'm going to use this illustration of In the Night Garden, which will be familiar to many of you who spent time with young children. So if we go through the different visual functions, there are more than are up there, but I've chosen the key ones. And we can start off with acuity, or the ability to resolve edges in space, to distinguish between edges in space. So a child with poor acuity being able to distinguish, pick out shapes and pick out objects in their environment. There are other functions, for example, stereopsis, the function that a child will use while reaching out for a parent's hand to grab it, for example, to walk across the road, being able to judge depth and being able to manage that depth in your environment. And part of that's due to eye movement. So either saccadic movements, which are looking from the structure in the garden on the left-hand side across the pinky ponk, going through the sky on the right-hand side. So being able to move your gaze from one object to another is another part of good visual function. And being able to track a moving object is another key function. Then we come to visual field. That's the island of vision that you have. And you could either have a peripheral defect of visual field affecting, well, the edges of the space as you navigate through a world, or something taking away very central vision, a space where you use to look at faces, to read fine print, for example. There can be disorders of contrast sensitivity. To show this adequately. I've chosen a monochromal image just to show that contrast is that ability to distinguish between the intensity of the signal coming from different objects, which is subtly different to colour vision. And of course, colour vision defects can come in many shapes and sizes. It's very rare to be completely monochromic when you have a colour vision defect. It's usually an inability to deal with certain colours. And then there's a function called accommodation. That is being able to shift your focus from something near you, such as that figure, the tombliboo in the front of the image, to the ninky nonk, the thing flying through the sky in the back. So being able to shift that side of gaze. So for example, turning from something you're reading in the classroom to looking at the whiteboard that the teacher's using in front of you, that accommodation function. And then we of course have the higher visual functions, the more complex tasks your brain undertakes in order to make sense of the world around them. Things like picking up items from a crowded scene, so being able to focus and really look in on one item within that picture in the night garden. Also, apologies. Also things like recognizing particular important items like faces. So being unable to distinguish faces being another type of higher visual function abnormality. A substantial impairment in any single one of these functions could result in a long-term negative effect on the ability to do a normal daily activity. So you could argue that a substantial impairment in any of these functions can be a visual impairment. However, the thing that we typically use internationally to define visual impairment is acuity. Acuity being the key visual function. Without that ability to distinguish shapes in space, it's incredibly hard to fulfill any of the other higher visual functions. I'm really sorry about the automatic pause, my fault completely, and hopefully you'll bear with me as we go through the talk. All right, so digging into visual acuity, the key visual function. In adulthood, we can use this thing that we call the Longmar chart, where the line near the bottom is what we call 0.0 logmar, or in old terminology, 6.6 or 20/20 acuity. So normal level of visual acuity, all the way up to the top line, which is 1.0 logmar. The top line that you'll find in any sort of optician's chart, and that equates to the old school of 660 or very poor vision. This sort of vision chart that you're used to seeing in your opticians is, of course, not so useful for infants. And for the first 4 weeks of life, certainly, we can use what the neonate's gaze pattern is, whether it's a steady gaze, to try and have some sense of what their visual acuity is. And by the time they're 4 weeks old, we can use the fact that infants prefer looking at complex, interesting scenes. We can use that preference to try and pick out how fine or how discrete or how granular a scene can be before the infant's no longer able to distinguish it, and use a preferential looking from a boring side of the card to an interesting side of the card to see whether or not that infant can pick up the grating that we're showing them. Now, I'd said earlier that we do use logmar acuity in order to differentiate between different levels of vision, and you'll hear more about that when you hear the slides about the BCVIS2 study. But an important thing to talk about when it comes to childhood visual development is that your vision improves with age. So on the horizontal axis is your age in months. On the vertical axis is the equivalent to logmar acuity, but as I said, 0 near the bottom of the slide being better vision and worse vision. So 1, 1.4, 1.2 being at the top of that vertical axis. Neonates are effectively born clinically blind or near blind, and the power to resolve items in space, to have improved acuity, that rapidly improves during the first 6 months of life. And by the time they're 3, 4, 5, they're reaching roughly adult levels of acuity. This rapid improvement, this maturation of the visual system is stimulus driven. It is dependent on stimulation from the outside world for you to see that rapid improvement of acuity. And that's not just acuity, that's the other visual functions as well. And that maturation is occurring during a window of rapidly decreasing sensitivity. And that closing window of sensitivity adds real urgency for the management of a sight-threatening eye disease in early childhood. We know that many of the functions that we have as adults, as they develop in the preschool years, they develop in the context of this closing window, decreasing sensitivity, be that number skills, peer social skills, emotional control, vision, or hearing. When it comes to vision, that's the white line of a closing window, decreasing sensitivity over time. That's like actually should be far steeper in the first 2 years. And that's because the first few months of your life as an infant after you're born, they're critical for establishing the necessary neurological connections that will enable you to see later on in life. Without the adequate stimulation in those first few months, your vision will not develop. The first few years of life, it's up to the first 3, 4, 5 years, as you approach that adult level of acuity, stimulation during that period is key to strengthening any established connections. And the first 8 years of life are really important for reconnecting if there's been some interruption in the high level stimulation you're supposed to get from the outside world in order to develop vision. Amblyopia is what we call poor vision due to abnormal development of the visual pathways, because of course your brain sees, your eyes give it information, but your brain is the thing that puts the information together to give you that view of the external world. So poor vision due to poor stimulation leading to abnormal maldevelopment of your visual pathways is called amblyopia. And early intervention in early childhood for eye and vision disorders is key to preventing amblyopia, because amblyopia, once it sets in, can be irreversible. It's key to reducing vision impairment in childhood. Okay, so now we'll go on to talk about vision impairment. And I'm going to hand over to my able colleague, Lucie Teoh, who's going to talk about the British Childhood Vision Impairment and Blindness Study, which was led by the head of our Vision Eyes group, Jugni Rahi. Lucie, over to you.
Thank you so much, Lola. So hi everyone, as Lola just mentioned, so I'm going to talk to you about some of the main findings from the British Childhood Visual Impairment and Blindness Study, or BCVIS-2, which Lola kindly introduced. So this study identified all children under the age of 18 years of age with a new diagnosis of full spectrum visual impairment, and that's using the WHO ICD-10 criteria, which I'll talk a little bit more about in the next few slides. So BCVIS-2 involved active surveillance through 2 schemes, the British Paediatric as well as the Ophthalmic Surveillance Unit, and this collected data from the managing consultant at the time of diagnosis, as well as 1-year follow-up. And through BCVIS, we were able to estimate the cumulative incidence of visual disability, which we found to be 1 per 1,000 children. And we were also able to report on the distribution of visual disability. Next slide, please, Laura. Thank you. So in terms of study aims, the BCVIS-2 study was set up to address an existing lack of nationally representative epidemiological data on all-cause bilateral childhood visual disability in the UK. And as many of you may know, the only national data available was from the slight impairment registries, whose definitions are not coterminous with the WHO classification of VI, of visual impairment, as well as the fact that registration is not mandatory. So in the absence of data to understand not only the national incidence, but the distribution across socio-demographic groups, this has implications for the planning and commissioning of eye health services and health policies, specifically in children. Next slide, please. Thank you. So in BCVIS-2, we defined visual disability using the WHO classification of visual impairment, as you can see here, which is based on visual acuity in the better eye. So children with full spectrum visual impairment, we defined included moderate visual impairment or moderate VI, in addition to children with severe visual impairment and blindness or SVI blindness. So thus an eligible child had vision worse than 0.5 logMAR, which is a conventional threshold for anticipating additional educational support such as low vision aids or large print. Next slide, please. So just to give you a brief summary of study methods as well as data collection, as I mentioned previously, there's a national ascertainment and data reporting occurred through the managing consultant ophthalmologist and or pediatrician. And they were reported through their respective national surveillance unit, BOSU or BPSU. And data was collected through a postal questionnaire, which collected sociodemographic as well as clinical information at notification and at 12 months follow-up. Next slide, please. So as you can see from the map of the UK on the left, the BCVIS2 study was nationally representative, and this shows the 89 hospitals as well as health centres where cases were reported to the study across England, Wales, Scotland and Northern Ireland. And a total of 784 cases of all-cause permanent bilateral full spectrum visual impairment were identified during the study period of BCVIS2, which was between 2015 and 2016. And next slide, please. So in terms of incidence, we found that the national incidence rate of full spectrum visual impairment, so that is moderate, severe impairment as well as blindness, was found to be 5.19 per 10,000 in the first year of life. And this increased to 10 per 10,000 children by the 18 years of age. Some three key findings were that, firstly, as you can see in the table, incidence was highest in the first year of life. Secondly, incidence is higher in children who have what we call referred to as VI+, so that is children who have additional chronic non-ophthalmic disorders or impairments compared to children with isolated vision loss. And finally, that incidence was higher in all ethnic minority groups and in the lowest socioeconomic group, which we measured using the index of multiple deprivation. Next slide, please. Oops, sorry, next again, thank you. So although we've established that childhood visual disability is relatively rare in the UK, these children are indeed a complex population at risk. There are over 70% of children in BCVIS were VI+, so they had additional major non-eye comorbidities. As you can see in the table on the left, these included things such as mobility impairments, epilepsy, and developmental delay. In addition to this comorbidities, we also found that childhood visual impairment confers a high risk of mortality. 4% of children with full spectrum visual impairment died within 1 year of diagnosis, of their ophthalmic diagnosis. The infant mortality rate was found to be 17.4 per 1,000, and this the infant mortality rate was measured by the number of children who died by 1 year follow-up who were diagnosed under the age of 1. And this rate is much higher than the infant mortality rate in the general child population, which is 3.8 per 1,000 nationally. Next slide, please. So here we can see the data relating to the causes represented by the anatomical site in the eye. The green bars represent all children in the cohort, and the red bars represent children with isolated visual impairment, and the blue bars represent children with VI+ or additional non-ophthalmic comorbidities. And as you can see here, there are really kind of striking differences in the relative importance of different disorders by the two different subgroups, isolated versus VI+. And you can see the three leading ophthalmic sites. So the visual pathways and cortex, the retina, as well as the optic nerve. Next slide, please. So in terms of each of these individual sites, the visual pathways and cortex, which we refer to as cerebral visual impairment, affected nearly half of all children with full spectrum visual impairment. And you can see here that hypoxic ischemic encephalopathy, as well as structural brain abnormalities were important causes. In terms of retinal disorders on the right, retinal disorders affected over 1/3 of children, and optic nerve disorders affected over 1/4 of children. In terms of retinal disorders, retinal and macular dystrophy, as well as oculocutaneous albinism, were leading disorders of the retina. And optic nerve hyperplasia, as you can see, was a leading optic nerve disorder. Next slide, please. So in terms of classification by the timing of insult or injury leading to visual impairment, we found that prenatal factors really predominated and are involved in 71% of cases. If you include perinatal or neonatal causes, they collectively account for 80% of disorders. And again, from the figure here, you can see that there are clear differences between VI isolated versus VI plus across the different etiological causes. Next slide, please. So from these two tables, you can see that there really are sort of heterogeneous causes in terms of timing across the different etiological factors. So for prenatal factors, you can see the leading causes were hereditary or genetic in origin, and hypoxic ischemia was the most common cause of visual impairment occurring in the perinatal or neonatal period. Next slide, please. So really to summarize, the findings from the BCVIS-2 study really show that full spectrum visual disability in childhood is indeed a sentinel child health event, and it's characterized by clinical complexity, vulnerability, as well as reduced life expectancy. And we also highlight that longitudinal data is really needed to understand the longer term health and educational outcomes to inform health policy and practice. Next slide, please. So now I'm just going to quickly switch gears to focus on children with severe vision loss only. So that is children with severe visual impairment and blindness, which I'm going to refer to as SVI blindness for brevity. So we recently reported a paper examining the temporal trends in the epidemiology of SVI blindness over the past 2 decades. And we compared data from children with SVI blindness from the first national childhood blindness study in the year 2000, which I'll call BCVIS-1, to the BCVIS-2 study, which was carried out in 2015. So comparing 2 studies that had identical methods and were carried out 15 years apart. Next slide, please. So we found, in terms of incidence of SVI blindness, that it was broadly stable over the past 15 years, and the incidence continues to be highest in the first year of life, as it was in the year 2000. We also observed persisting socioeconomic and ethnic patterning and incidence. Sorry, next slide, please. I think there's a transition here. Oh, sorry, there isn't. But just to say from the last slide, that there were higher rates, higher incidence in children of non-white children compared to white children. Thank you. Next slide. Thanks for that. In terms of survival beyond the first year of ophthalmic diagnosis, we found that the mortality rate decreased significantly from 10.5% in the year 2000 to 5.6% in 2015. And there was a parallel reduction also in the infant mortality rate. And alongside this increased survival, children diagnosed in 2015 were found to be more complex than children diagnosed in millennium, with a significantly higher proportion of children with VI+. We also observed a dose response gradient between birth weight and all-cause SVI blindness, which you can see in table 2, and this gradient seemed to increase over time. Next slide, please. So in terms of the specific ophthalmic disorders, we observed an increase in the relative contribution of a cerebral visual impairment, which, as a reminder, was disease or injury to the visual pathways of cortex. And this increased from 50% to 61% between studies. In terms of the timing of injury, in terms of the etiological causes, the proportion of children with hereditary conditions increased from 35% to 57%. So really, what we found was that tackling cerebral visual impairment remains the biggest challenge in reducing the burden of SVI blindness, and that there's really a significant importance in genetic testing and the development of novel gene therapies in terms of treatment. Next slide, please. So just to say, just to summarize, really there's been overall, there's been sort of a change and a changing landscape of healthcare, and this is reflected This has been reflected in improvements in survival, as well as a concomitant increase in clinical complexity and heterogeneity in SVI blindness. So this really underlines the importance of multidisciplinary management between ophthalmologists, between ophthalmic and pediatric specialties. So I will now pass you back to my colleague and academic supervisor, Lola, who's going to talk to you a bit about the detection pathways for childhood visual impairment.
Thank you so much, Lucy. And thanks to robust study design, but also thanks to the fantastic support from BOSU and from BPSU. We're also able to talk to the pathways to detection for children with vision impairment, severe vision impairment and blindness. And these data are critical for planning services for at-risk or for affected children. And prior to BCVIS2, there was a lack of evidence on the patterns of detection for children with a full spectrum of vision impairment, as Lucy said, going all the way from moderate vision impairment, where we know you need extra support at school, all the way to really densely poor vision to blindness. So the three key paths that we reported through BCVIS2 were detection through symptoms of poor vision, through detection through routine health screening, and through targeted surveillance of groups who were known to be at higher risk of having poor vision. So that's children with developmental disorders, neurodevelopmental disorders, in whom we know the cortical insult means that they are likely to have poor vision, but also children who, should they have poor vision, because of dual pathology, we know that that additional burden of having poor vision makes a significant negative impact, a compounded impact on their chance of being able to lead the life they deserve to lead. So, for example, children with sensory neural hearing impairment being both deaf and also having severe vision impairment being a real double whammy. So the largest group when it comes to detection were those detected through symptoms of poor vision. So parents and carers reported concerns in only 55% of those who had symptoms of detection. So pathway either was parents and carers noticing concern, or a non-health professional noticing a concern and escalating that, or a visual concern being noted in the context of, for example, an incidental a medical trip or a medical trip for another reason. So in only just over half, parents and carers had noted a concern. And when we looked at the population of children with moderate VI, families living in socioeconomic deprivation were significantly less likely to report a symptom for a child who would present symptomatic at detection of the eye visual problem. Another key pathway was targeted surveillance of those high-risk groups. So when it comes to high-risk group, and by far the largest were children who had neurodevelopmental disorders. And having heard Lucy talk so well on the fact that so many of these children had cerebral vision impairment or cortical vision impairment, that isn't the greatest surprise. But there also were families who were detected in the context of a systemic disorder that put them at risk of eye or vision disorders, having a family history of a visually significant eye problem, or children who were born preterm or low birth weight, either because these children were part of the retinopathy and prematurity screening program, or due to another surveillance because they were born in poor state. And when it comes to the professionals involved in detection, for this table, really, the two rows to look at, the paediatrician, the community paediatrician and hospital paediatrician, by far, the most commonly involved professionals when it comes to that first, earliest stages of detection are paediatricians. And when we come to how many children are detected to have visual problems through the routine health screening processes, that's a fifth. So it's the least common, still significant pathway, the least common pathway for detection of VI or blindness. And just to go through what sort of screening we're talking about, well, the newborn and infant physical exam, or NIPE, is part of the physical exam for every child born in the UK. In the first 72 hours of life, you'll have a red reflex test, a light examination of the eye to pick up any gross congenital abnormalities. The primary target disorders, cataract or clouding the lens inside the eye. There will also be a safety net examination at 6 to 8 weeks. And this is part of the hips, testes, eye, and cardiac examination that happens as part of the NIPE. And the fact that cataract and those some gross ocular anomalies are included within NIPE speaks to the fact of the importance of detecting a treatable condition in those first few weeks of life, because we know that you've got to allow that visual system to have high quality stimulation if you want to give that child a chance of good vision. There's also a whole population screening. There should be a whole population screening examination undertaken at 4 to 5 years of age, reception year at school. So that's the bottom row on this table. And that's a vision assessment of each eye separately in reception year, undertaken by orthoptists who are allied health professionals, a terrible term, but health professionals who specialize in understanding visual function in children or those with eye motility problems. So that check is supposed to happen across the whole population. An indirect whole population assessment of visual function is buried within the Healthy Child Pathway. It has different names in the 4 different nation states, but that's indirect testing of your visual function as part of testing the fine motor skills that all 2 to 2.5-year-olds go through. And also as part of that Healthy Child Pathway at that milestone, and of course through the Red Book before that milestone, parents are encouraged to report any visual concerns. So within the BCVIS2 cohort of 784 children, 92 were picked up for the newborn exam, and a further 31 picked up for the catch-up exam. 11 were picked up at the 4 to 5-year-old vision screen. But that small number, isn't it surprising when you think about the fact that uniocular amblyopia, that sort of picking up and as previously undetected poor vision just in one eye, because a child may not have noticed that there's just poor vision in the one eye, they may not have noticed that with both their eyes open, they can't, the one eye is lagging behind. And there were other sort of unclear pathways, which you weren't entirely sure which screening program, but the clinician had felt the screening program and picked that child up. But in total, 1/5 of children, so it wasn't the largest pathway. So overall, symptoms of poor vision was the greatest pathway, followed by targeted surveillance of those high risk groups, followed by routine health screening. That just really speaks to the importance of making sure that professionals and families are informed on what to look out for when it comes to visual function, the normal milestones for childhood, making sure that we really push the fact that children in high risk groups do need to undergo this targeted surveillance in order to pick up poor vision at an age where there can be some extra support given to these families. All right, so now we're going to talk about visual impairment and how it impacts on the individual. You've already heard about how it impacts on all the milestones in the Red Book. But visual impairment can impact on the development of mental processes such as logical memory and language. Let's go clockwise. Impacts on the ability to detect non-verbal cues or clues, which results in a delay in building up an understanding of social situations. It also impacts a child's awareness of the impact of their own non-verbal gestures or expressions on others. It impacts on the time needed to take in information, even non-visual information. And of course, it impacts on the perception of the immediate environment, on objects around them, and how to pick up, where you can learn more about the information about the world around you, and also the perception of the other people around you. And work is undergoing right now within the Eyes and Vision group to really deepen our understanding of what the impact is of child with visual disability. What does it mean to be a visually impaired child or young person? What's that real life impact on health outcomes, educational outcomes, social interventions? As I said before, so our lead of the group is Jigni Rahi. She's worked extensively in this area, describe what that real impact is at not just a societal level, but also individual level. And one activity that Jigni's led on is development of novel and now validated and in clinical use vision-related patient-reported outcome measures that are child and young person specific. So there was a child and young person driven approach to developing and validating these instruments. And there are now instruments on the vision-related quality of life and also vision and functional vision questionnaires as well for use in both clinical practice and in research. You've heard, of course, quite a lot from Lucie, and you've heard at the beginning of the talk, Diane describing Lucie's PhD on long-term health outcomes and healthy use of children with vision impairment and blindness. And another student within our team, Anna Shemrov, is looking at resilience mechanisms that help shape the quality of life outcomes for children and young people with visual impairment and their families. And, we're really proud of the breadth of work that we're doing. So, for example, one of our IBSC students is attached to us is looking at barriers and facilitators of positive experience of menarche, so the start of menstruation for people with visual impairment. We also have a program of rare disease research, because we know from BCVS 1 and BCVS 2 that collectively, although individually rare, individually uncommon, collectively, rare diseases are the commonest cause of childhood vision impairment, and blindness. So we're undertaking work on congenital infantile cataract, undertaking work on inflammatory eye diseases, both imaging, but also developing patient-reported tools on disease activity. I'm also doing work into how to best support children who do have child onset rare disease that affects the eyes, and how to support them and how they self-care. So the points that we'd like you to take home from our talk are that visual disability is a marker for global vulnerability for that child, that individual, and they should be, because they're not yet incorporated as a key child health metric. The majority of children will have additional non-ophthalmic disorders or impairments. Infant mortality rate is 4 times higher. These are vulnerable children, and there is strong socioeconomic patterning. So vulnerability compounded on vulnerability, compounded on vulnerability. These children have significant health, education, and social care needs. There's an ongoing need to support families in recognizing concerning symptoms. The majority of disease remains unavoidable, and although it's not increasing in incidence, it is increasing in complexity. Okay, let's end the talk with a celebration of the achievement of young people and children with visual disability. So I'm a trustee for the Royal Society of Blind Children, and there was a recent open day which was based around music and crafts and encouraging young people and children with visual impairment to really get involved in those activities. And there's this beautiful quote on the side of the building, aerodynamically the bumblebee shouldn't be able to fly, but the bumblebee doesn't know that, so it goes on flying anyway. So we'd like to acknowledge our funders. Thank you so much for your interest. We need to acknowledge Jugni, the head of our group, who gives such fantastic leadership. And thank you for your attention. I'll stop the share.
Thank you so much, Lola, for an amazing, and Lucie for an amazing presentation. I certainly learned a lot. It was really interesting. I actually wrote in 2 questions in the Slido. So if anyone has any questions, could you please put them in the Slido? Or if you would like, you could put them in the chat and I'll read them out loud. One of my first questions was, I'll just kick it off to start. Do you think COVID had an impact on visual impairment if infants and children had a lack of stimulation during the lockdown periods?
Yes, I mean, we already, obviously the answer to your question isn't as simple as yes, but in one way it is. We already know that the impact of the withdrawal of stimulation of social interaction had a significant impact on global childhood development. We know that children, sort of turned up to the nurseries not having reached the social milestones they would normally have. We know that educational milestones weren't being reached. We know that there was strong socioeconomic patterning when it came to these milestones. So we know that globally, child development was impacted, perhaps not irreversibly, but we know that it was impacted. And as we argued, childhood visual development is integral, it's key, wrapped in to all those other developmental milestones. So it would be foolish of us to say that even though we don't yet have the specific data we need to describe what visual development was, it'd be foolish of us not to assume that it was impacted in some way. But we don't know how irreversible it is, because we don't yet know how those other milestones being shifted, how reversible that might be. And we don't really know the shape of it. We don't really know whether, which sort of visual functions. I sort of described earlier at the beginning of the talk, the range of visual functions there can be, from simple reading letters on a chart to more complex Where's Wally activities where you have to take out a stimulation from, take out an object from a really crowded scene. So we don't know quite what the shape of it is, but it'd be really foolish of us to not think that vision stood alone away from all the other developmental milestones is something that wasn't impacted. There are also interesting questions around the other impacts on vision development. For example, we know that short-sightedness, the increasing epidemic of increasing burden of short-sightedness across the world is linked to failure, not failure, that sounds punitive, that's judgmental, doesn't it? but reduced time spent outdoors. We know that that's one of the key risk factors for children becoming more and more short-sighted. And of course, we know that an inevitable consequence of the time spent indoors will be higher rates of short-sightedness. But again, what will be really the functional impact of that? I don't mind overly being short-sighted myself. What will that really mean for the lived experiences of the children who are affected? So sorry, long answer, but it's a really interesting question and a complex one.
Oh, no, that's great. Thank you. Does anyone else have a question? So people are asking if you had, will they have access to the slides afterwards? Would you mind sharing them?
So the recording will be shared. The slides have been presented either from work that is in the public domain or work that is just undergoing proofing, so will be in the public domain soon. But nevertheless, we prefer if we didn't share the slides for now, and you can just have a look at the recording. Thank you.
Okay, great. Does anyone else want to shout out a question if they don't want to type it? Someone's raising their hand, but I can't see it. Gina.
Good news.
Thank you. Thanks, Lola. Well done, Lola, Lucy. Thanks, Diana. So one of the things I just wanted to raise was, in addition to the really, really great question just now about, what happened to the development of vision for very young children during lockdown, is something that a lot of people probably haven't thought about, but you can imagine people living with vision impairment, adults and children, have said a lot about, and a lot of the sight loss charities have commented on, is that I don't think a lot of people realize what it was like to try and, for example, do physical distancing, social distancing, if you're visually impaired. The challenge it was to be outdoors, out and about, with those various restrictions. And actually the enormous challenge it was to pivot to online education for children when schools were closed. So there's a really, really significant hidden impact that, as Lola says, the shape of that is going to take a while for us to really understand. And it's like so many areas of health, there are pre-existing inequalities. Lucy's demonstrated, how risk of all-cause vision impairment, varies by key socio-demographic factors. But this is another area of kind of what we can expect to be a widening of inequalities. And so, for us, it's about trying to, make sure people understand about this particular form of, type of disability, if you like, when we have these conversations about the broader impact on children and young people living with disabilities. Thanks.
I have another question just to follow up. If Juno or Lola or Lucy could answer it. Just to follow up. So looking at sort of socio-political determinants of health, did you look at visual impairment by migration status? So no recourse to public funds. So I work with families in temporary accommodation, and I've been interviewing health visitors who work with families in temporary accommodation, and they've been talking about some of the delays that they've seen in children, but they were saying that children in temporary accommodation in particular are more risk because they don't have access to certain things.
So really good point, and really good question. So there's 784 children within the BCVS cohort, and we did collect data on where they were born, for example, and we did collect social support that their children needed. But I think that a cohort of 780, because it is 1 in 1,000, is relatively uncommon. It might just be that we didn't have the power to look at that. But I think it's anecdotally definitely something that's of a concern. We know that late diagnosis can arise from delayed access to timely healthcare, but it's not something we can answer from BCVS 2.
Oh, Diana, you're muted.
Oh, sorry. Mario has his hand up.
Thank you. Very interesting talk. Thanks very much, Lola and Lucy. Just a very simple question, and I hope you haven't said this before, but Why the huge difference between the mortality in this cohort and the general population? I mean, is there a simple explanation for that? Are there comorbidities in particular, or why? I mean, it's just huge. Thanks.
Yeah, I'll just start. I think by yeah, I think that's a really good question. I think I think the main point really is to say that we're looking at children with rare disease, so and they have significant comorbidities. So this is and it's the comorbidities that were it was the non-ophthalmic disorders that were the cause of death in all these children. They were really really quite significant and serious. So so it's a constellation of sort of very significant rare disorders. So that I think there's there's that differential, but I don't know. Sorry, Lola, if you want to add anything to that.
Absolutely. No, you hit the nail on the head. It's the comorbidities. We're not suggesting that any of these children died as a consequence directly of the fact they had poor visual function. It is their comorbidities. These are children who are born preterm or very preterm, in a low birth weight, in a poor state. They're born with hypoxic ischemic insult. They're born with significant other impairments, be that mobility or learning difficulties. So it's that, is a perfect word, Lucie, constellation of other defects. So it's not often not one, it's multiple defects as a result of them typically having an insult development very early in development. And the sort of, the magnification that occurs as the child ages. Jubilee's online.
Thanks.
So I was just going to expand though on that. So that's exactly right. But if we move away from high income settings, being visually impaired is really going to affect your life chances as a child. It's going to very much impact on resources that are available to you if your family has limited resources. And if you're an adult, it absolutely does have an impact on your survival if you particularly are unsupported. So there is something about the direct impact also in terms of your ability, I mean, even just to deal with kind of threats to your health and so on. So in other parts of the world, one would expect there to be an association that isn't through what we see in high income settings as we've seen in the UK. So just worth remembering that there is a direct impact as well, as far as we are aware.
Yes, thank you.
I'm checking the Slido. I don't see any new questions. Does anyone else have a question? Otherwise, I'm happy to wrap up the seminar.
Thank you for those questions.
Yeah. I found the talk absolutely brilliant, and I'm sort of buzzing with questions, but I will email you separately because I'm very interested in sort of the socio-political determinants and how that impacts disability. So I will contact you afterwards. So thank you again to Lola and Lucie for an incredible presentation. Just to let everyone know, we have an additional seminar tomorrow at the same time with Dr. Michelle Hees, and hopefully we'll see you there. Thank you.
Thank you.